Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi taala wabarakatuh, and very good evening, everyone. So, a warm welcome to all of you joining us today for, I believe, insightful session by MedTweetMY on fundamental of pain management strategies every clinician should know. So, my name is Dr. Mafeitz, and I will be your moderator for tonight's session, and it's a pleasure to be with you. So, to begin with, let me recall a bit on fundamental of our topic tonight. So pain, as many of us know, it's more than just a symptom, and it's often like a multi-dimensional experience that affect both physical as well as emotional well-being of the patient. And effective pain management, I believe it goes beyond just administering medication, not just drugs, but it involves understanding the underlying cause, selecting the most appropriate intervention, and of course, we want to tailor them to the specific needs of the patient. And it may range from pharmacological treatment, drugs, or even non-pharmacological methods such as physical therapy, massage, psychological support. And I think as a clinician, staying up to date with the evidence-based strategy is crucial, important, because pain management protocol continue to evolve. And with the rise of drug crisis globally, there's increasing emphasis on the balancing efficacy of the safety as well as patient-centered approach that minimize the risk while maximizing the pain relief. So that's why in tonight's session, we will discuss into the key principle and technique for managing pain. And our expert speaker today will touch upon the latest development in pharmacological management, the role of anesthesiology in acute and as well as chronic pain setting, and strategies to integrate both medical and maybe non-medical approach to achieve the best outcome for the patient. So it's a very important whether it is outpatient care or maybe emergency or palliative care. And I hope knowledge gained from tonight's session will be invaluable in enhancing our practice. So tonight we are fortunate to have Dr. Mafeitz Mamat here with us, a highly respected consultant anesthesiologist from Sunway Medical Center, University KL. And with his extensive experience in anesthesia and pain management, Dr. Mafeitz will be guiding us through today's topic, sharing valuable insight and practical approach to pain management. So before we begin, a few housekeeping notes. This session will approximately 40 to 45 minutes long, followed by Q&A segment. And please feel free to type your question in the chat. We will try to address them during Q&A sessions. And attendance link will be provided at the end of the session. Please fill it up completely for e-certificate as well and also for the MMA CPD points. And all right, so without further ado, let's get started. Dr. Mafeitz, the floor is yours.
Okay, Bismillahirrahmanirrahim. Thank you very much. Good evening to everybody. As this is a midweek session that we have today, thank you for attending. And I'm just going to share screen as well as share my experience when we talk about the topic that we have today, the fundamentals of pain management strategies clinicians should know. I think it is something that is in our what we call the MedTweetMy back to basics. So I'm not quite sure who are the audience that I have today, whether it's from the initial stage in medicine or maybe people who are senior. But otherwise, it is a big note to note that pain management is something that you and I and everybody, all clinicians will come across, and sometimes it is something that we take for granted. All right, so let's start. So, okay, pain, sakit, tong, valikida, pain, I'm sore. So all these things are something that is already embedded, and we are brought up with this concept of understanding, or I'm not too sure whether we say understand, but that we portray and we tell as we learn and describing what pain is all about. And I guess pain is something that from when we are young until we become to who we are at the moment, that we have different interpretations. I mean, as a Muslim, there's this one thing when we talk about pain, pain is something that we do not want to endure, and it actually forecasts a certain future that we would like to avoid. So it is meant to be whether you have somewhere in the grave or the hereafter, they're talking about the pain that you have to endure again and again, and it's something that we forbid as something that is being centered. So here is one part in terms of education of pain, and I guess in probably different societies we have different kind of thought. As we can see, the burden that in terms of report that people would describe pain everywhere in the world, and as you can see, obviously everywhere. I think in the statistic that they show the dark rate, there is China. I mean, obviously, because their population is the biggest in the world. But yes, everybody, the population, they expected to experience pain in each country would not vary much, because it is everybody would report that they have pain. But in terms of how we manage it, we think we have managed it well. But from developed country managing or attending it to the non-developed or barely surviving countries doing it, there's a big variation of pain management. Developed countries may think that, yeah, because they have the best research, they have the best understanding, the best clinical management, that don't know best. But we go to that one extreme, which I'm showing you here. These are the two Netflix series, which is very, very informative. Because if you not know, you have not known, and I suppose for epidemiologists or even public health should know the fact about what we call the opioid crisis. What happened in this opioid crisis is an epidemic caused by the drugs. And in particular, with this show series, we're talking about the opioid crisis in America, where what happened after that 15-year stretch, there are quite a number of population deaths are caused by opioid overdose. Then this is something that you would consider, takkan pula. And it is interesting how pharma and how the society thinking that they're addressing pain in their quest to look for the magical drug, magical bullet, and they end up creating issues and problems which currently the world is facing now. So it is quite interesting. I mean, I would encourage you to go and have a look at the series rather than tengok cerita-cerita yang kadang-kadang tak bermanfaat. At least this gives you some information, and you see how the pharma approaches this in terms of their marketing, how they use marketing and deceive the public, saying that the particular medication is not addictive. Kerana semata-mata FDA dah luluskan. So interesting, isn't it? And how this manipulation in the end habis. And to the other extreme of places that we know now, more than 340 days, almost a year, the biggest humanitarian crisis and the clinical crisis that we have there is no access of pain relief management and managing pain, as how I was there when I went there. The hardship of delivering adequate pain management and having to balance out with the limited access that we have. So you can see the discrepancy in terms of how we manage pain and how we think we are doing it. So what are the challenges when we talk about pain management? Number one is a failure to recognize or differentiate pain from anxiety. This is something more obvious in countries who are developed, where the expression of feeling should be taken into consideration compared to maybe the non-developed, where you said, okay, no, that's not pain, or you define it yourself as a clinician. Lack of education for healthcare providers regarding non-pharmacological modalities. So this should be known. I will go through this later. Safety concerns, fear of patient addiction or prescription. Ni pun satu hal juga. We think that this patient ada history of opioid, then you decide that maybe you want to limit them when it is actually against human right and the pain management to not give them that adequate pain relief. Lack of existing patient-physician relationship, knowledge of past medical history, inadequate discharge pain. Maknanya just because nak discharge, then later patient present in ED because of pain. And pressure to see patients rapidly. I guess this happens in our clinics when we have about 50 patients waiting out there, or even in the green zone. Everybody coming and we just like, okay, sakit mana? Okay. And just prescribe without looking really properly. So it is not as easy as one thought in terms of managing pain. And we think for granted that we have done well. So I guess before we go through the talk, I'll just put on these few take-home messages, and these are actually the core. Because kalau you tak ingat, kita cakap about 40 minutes ni, at least you take the number one. We talk about the pain burden, and what I want you to know is regarding acute pain versus chronic pain, how the assessment and management should be holistic, and what we call the magic keyword dalam pain management, multimodal approach. Multimodal approach. Alright, and again, this the pain A, B, C, D, E. Bukan susah sangat ni. This is by 1992 Jacob saying something that we in the sense of talking about knowledge of pain. A, ask patient regarding their pain level regularly. Assess the pain systematically. B, believe patient's pain level. Ini yang susah sikit ni kadang-kadang ni. Because we think they don't come in and we think it is not as serious as how the patient described. Believe patient's family on effective pain relief method. C, choose pain control option appropriate for the patient and setting. Deliver intervention timely, logically, and in coordinated fashion, and empower patient and family in the pain management. So it's a whole process. Alright, ladies and gentlemen, kita tak payah cerita. I mean, I can talk about WHO, Pain, International Pain Society, but currently in Ministry of Health, we have these 4 good publications. If you would like to endure or at least have this either in your smartphone or in your physical form. Number 1, the Pain Management Handbook. Ni semua baru-baru ni. Edition of 2022, I think. And Pain SP Vital Sign, the 3 editions. I think last is 2021. ED came up with the second edition 2020, pain management in emergency department, even from the pharmacy side, pain pharmacotherapy services. So there are guidelines and really good details, and I guess a lot of the content that I have in the stock are the combination of these 4. But of course, when we talk about pain as with vital sign, that is pretty standard that we all as clinicians should know, and how it affects the other vital signs. How the increased sympathetic response can kacau everything just because of pain, and you don't manage pain well, and all the other vital signs would just go haywire. Alright, so the definition of pain, kalau when I was a trainee, and this is something that kena hafal, tak hafal ni fail exam, the ISP definition 1994, defined as unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. So it is this definition by your patients, by the person. In 2020, however, they have revised this. They have satu panel because they know that there are certain parts which are not really defined, where they pecahkan lagi. They expanded upon the addition of 6 keynotes. Number 1 is always a personal experience. 2, pain nociception. Okay, this is a definition. Ada definition. Different phenomena. Pain cannot be inferred solely from activity in sensory neurons. And pain through their life experience, individuals learn the concept. A person's report experience of pain should be respected. Ini actually rule number 1 ni. And sometimes yang kita lupa. And a person's although pain usually serves an adaptive role, it may affect function and social psychological well-being. And verbal description is the only one of the several behavior to express pain. So all these six key points yang add into the definition when we talk about pain. So bila kita do pain, what is the objective? Definitely to improve pain. That means to relieve the suffering lah. Increase safety, efficacy of the anesthesia. They avoid effective manage the side effect of the treatment. Ini penting. And facilitate the recovery process. So these are the important objective why you would attend pain. And because if you don't, what will happen is when you do not recover, ini dah cerita masuk to public health side lah. How the burden yang akan affect economy, affect the country. Because of that simple concept of pain which is not managed well. Another interesting point about pain is for ICD-11. Dia dah masuk banyak for the MG, from the MG for mortality and morbidity. Maknanya, when you put in the ICD-11, dalam your certificate cause of death, if it's not the first, second or third, this can be put as cause of death. Because it's ICD-11. So this is something that we, I think the whole world, not just Pain Society, but WHO see this as something that is important and is a cost. So it is in. So ini penting ni, important, because previously it is very generalized when we talk about chronic and acute pain. So when we attain health, we were talking about managing the whole person. Jadi it is the combination of all. Ini dah cerita pain from the public health side ni. But it is important because when you understand this, it is just not about prescribing the medication. How many times have people, even your family members tell you, dia datang to ED, aduh sakitnya tengok, Tapi bila doktor datang, 60% of the pain is gone. How many times have you heard this? How many times have people tell you? So hence that communication and the understanding, the empathy to understand a patient problem plays important role in pain management. There are 7 dimensions of pain. Macam tadi kalau tak faham ayat panjang-panjang sangat, so we put this in a particular simple depiction. Physical, cognitive, sensory, affective, behavioral. So these words are defined on its own in terms of when you describe pain and how these are interrelated and affected. And of course, the spiritual point and the social culture point. All right. Then the biopsychosocial factor are all actually interlinked and they impact each other. As you can see, when we talk of biological, it's the basic sciences in terms of when we talk about the organs, the cells that is damaged or muscle that is having any issues. So these are the particular issue and it depends on the pathology. The pathology of pain ni penting juga, macam mana dia datang and what it origins and how it takes. The psychological and behavioral, because it affects thought, it affects mood, it affects sleep, and all these 3 will affect the recovery, whether the pain will be healed totally or not. And of course, when we talk about social, is the support and your access and culture. Alright, because pain ni dia, in general dia ada banyak. You're not talking about just pain jatuh, pain accident. You have this chronic pain, you have cancer pain. At the same time, labor pain. Ini labor pain. How people manage accordingly. Kalau dulu kan how labor pain kita tengah cerita nenek 2-3 hari sakit kan, macam sekarang apa ni tak boleh. But then again, in terms of how we manage labor today, in modern days, that how kita induce and we give that extra hormone to encourage the contraction. So that tallies of difference in terms of how cope and the behavior. When we go back to basic science, we should know that how things work. Macam mana, kenapa the nerves would, I mean, as you know, there are a number of nerves and there's our senses that we have, kan? Ada heat, ada touch, and etc. All these are the normal, and of course you have your pain fibers. And how does the pain need being perceived is when there is a damage. Kan kita tengok the definition before. When there are physiological damage, for example, katakanlah you fall down, jatuh, okay. So what happens? Dia ada bengkak. So it is inflammation. So when inflammation happens, as you know, there are lots of changes that happens. All cytokines, and you have say bradykinin would be one of the things that would affect. And this would, so that dia transducer kepada that free nerve ending, and dia akan go around that area from your peripheral go to your dorsal horn, maknanya tengah dekat spinal cord. Dekat sini dia akan berkumpul. They change, interpret, and then they go to ascending tract naik ke brain, which is in your reticular activating system or your caudate gray area, and interpret your sensory cortex thalamus, and with this interpretation, dia turun bawah balik, giving that response or the increase sympathetic activity, etc. So this is pain. For example, you rasa macam panas, then of course kita ada warm sensation, it's okay. But when it is too hot, when dia ada kata, ada nerve, ada tissue damage is happening there, then inflammation starts, and dia yang start to affect the nerve, dia banyak-banyak. And of course, they go down to the dorsal horn and they interpret. So dia ada banyak-banyak. This is where, in terms of how we manage when we're young, kita jatuh, what do we do to our kid? Sayang, kita tiup, kita sapu. So we're giving all these mixed senses, kan, pain. So then the interpretation, this is where the pain gate theory dekat spinal cord tu, dekat dorsal horn comes in, where how you can kita panggil tu flatten out that pain so that when it goes up, interpreted by whatever up the brain to say whether it's very painful or not. So macam saya cakap tadi, dia jatuh, katakan macam panas sangat, sakit. So what happens? To protect, you let go. So that is the response that we have. Example. So that's where ini yang paling konsep penting lah when we talk about nociceptive. Tadi that word there called nociceptive, or the initial inflammatory pain, the normal acute pain that we have. And again, when we talk about clinically the assessment of pain, simple pain history, PAIN lah kan. Where does it hurt? What makes the pain worse? Sakit tak kalau tarik? Intensity, what is the pain score? This is one other factor that as a clinician that we ask lah when we talk about pain score. and a nature and neutralizing factor. So we have to have that particular right description about pain, like aching, throbbing, burning, electric shock, shooting, stabbing, and what makes it better. So pain, simple abbreviation kita ada ni, PAIN. Place, gravity factor, intensity, nature. Ni pain scale score ni. So the important yang kita ada the simple VS pain scale, simple. 0 no pain, 10 the worst ever pain that you can feel. So in between lah. So dia ada macam-macam cara. The important part is that numbering, but you have to make the patient understand, and you yourself understand and tally that. Kalau susah sangat, kita panggil dia, kita punya face punya scale. And this is kita evaluate in terms of macam mana. Tapi kalau orang tu dah macam joker senyum, sakit pun tak tahu kan. So it's that interpretation of how you, when you ask and when you cater. So I mean, of course, when we talk about pain scale, it transverses language. If you are able to tell macam mana between 0 to 10 lah. But then again, remember, it's patient's perceptions. Patient's 5 may not be the 5 that you think it is, or patient's 8. And depending, dia 8 tapi dia senyum lagi. Dia kata, oh, my pain score is 8. So, where to believe and how to do. This is somewhere where you have to know and understand when they say that and their own interpretation. Okay, kalau baby pula macam mana untuk budak-budak? We just be there. Of course, there's another skill. The carer punya interpretation as well as how you see in terms of their movement. Tapi I will not go through that lah because it's definition. But you know that this pain scale score is important because this will help us with our management. Again, tadi kita cakap pasal acute pain and chronic pain. What is the difference? Acute pain tadi cakap nociceptive. Chronic pain neuropathic. So acute pain tadi, as I mentioned, it is something yang can heal. Something macam inflammatory. So bila you settlekan inflammation, dia boleh heal. But in acute pain yang jadi chronic pain ni, if you do not take care of that pain properly, it can indeed in the end irritate the nerve and becomes chronic pain. That's why it's called neuropathic. And of course, when it creates chronic pain, it is something that is maybe not solvable and patient have to live with that. So it becomes very, very, very problematic when that happens. When we talk about simple, there are a few things that we know where in terms of pain, kita ada acute, chronic. So onset, simple, okay, acute. I mean, English word itself tells you what and what's chronic. So dia ada time punya factor. So when we look at this, so we have to know dia punya duration lah, which is usually the magic number is 3 months. Either less or 3 months, but more. But bila ni is we say the same part or same area lah. Kalau dalam 1 bulan dia sakit sini, setiap bulan sakit sana, and sakit sana, and then say, oh, more, of course it's more than 4 months, I dah sakit kan. So that's why again, that initial history, where exactly site tu penting, and you see why. Why to tanya why and what is the initial cause of pain is very important, and that's where in our clinical judgment in everything that we do, the cardiology, respiratory ataupun surgery, pain kan, where the pain kan. Chest pain. Chest pain kat chest lah, mana lagi. Alright, so when acute pain is actually a signal of actual or potential tissue damage. As I mentioned, inflammation. Chronic pain maybe dah tak ada dah, tapi because the nerve itself tu dah kacau. That's why it's called neuropathic pain. And the severity correlates with damage. Kalau chronic pain, sometimes depends, because sometimes dia akan throbbing more, sometimes depending on what are the aggravating factors. Again, the psychological effect, dia ada tu. Tapi okay, the common example kan, macam acute pain. Example, your surgery, post-surgery, fracture, jatuh, burns, cut, labor, childbirth. It should be acute pain, intense in that labor process. MI. MI ni memang acute lah. You acute, then either you live or you die. Then of course, the other inflammation or sepsis, etc. lah. Certain part, you may get that. Chronic pain. Apa? Headache. Low back pain, sakit belakang, sakit kepala, not something sometimes not easy to manage. Okay, if you rule out the headache punya issue, people come in with headache kan. You and I do have headache. Nak prepare presentation ni pun headache juga. Tapi tak low back pain lah, because ada good ergonomics. And then we talk about cancer pain. This is also another factor due to medical disease macam arthritis pain. Your chronic pancreatitis, chronic abdominal pain, sometimes post-infection, macam kita panggil di post-herpetic neuralgia. Or even simple as diabetic peripheral neuropathy kan, dia macam pedih sakit je. So even stroke pun ada pain. So even though patient are badly stroke, you cannot assume that they are not in pain as well. So the assessment and understanding this is very important in how. But again, chronic pain is totally an issue that maybe I will not touch much in this talk. So we talk about acute pain because this is where you and I memang we manage this every day in our own setting. Alright, again, when we talk about this nociceptive and neuropathic, macam I cakap tadi lah. So I think I have maybe summarized that earlier. Tapi interesting to note regarding the nociceptive is the description of pain. Okay, nociceptive selalu because it's just something that is acute. So you get more of the sharp and throbbing and you can actually localize it. Neuropathic pain sometimes can be burning, shooting, stabbing. Ini yang betul-betul dia post yang macam neuropathic lah or polylocalized. But again, headache is a migraine though. You can consider and put that as the chronic pain. I mean, you don't describe it as such, but that duration and you will get on and off and it will not be solved easily. Okay, yeah, again, the cause of either is an obvious tissue damage or nerve injury. Okay, now we go in terms of management. I think the kita punya moderator I mentioned tadi in terms of when we manage it, we're talking about non-pharmacological and pharmacological. And the keyword is always sorry ni ada tengah multi-O pula. It's actually multimodal approach. Alright, where you don't aim for one, but it has to be holistic and understanding of how things is. Even in acute pain, tak boleh just medication doesn't solve it on its own. Because pain is not just a physical experience. It's a biopsychosocial punya integration. So all these factors and person experience with their environment memang contribute to the pain. Some people who are used to, macam mana nak cakap nanti salah cakap ni. Dia kalau rotan-rotan ni bahaya dia sekarang GISB lah apa cerita. Okay lah, in terms of certain culture, then maybe we also have our own apa kita panggil tu, our own biasness to certain people that you say dia ni tak tahan sakit, dia ni macam manja, manjalitis lah, so many words that we have in our fraternity, which is plus minus, but again the understanding of patients own personal experience and the behavior where they come from. Ni penting juga ni for you to manage. What are the basic, nanti nak cakap about four piece of pain management tu. Remember, because statistics say 1 in 2 people consider themselves to be suffering from pain. I tak sakit, so somebody else sakit lah. So ada 2 orang me moderator teruk sakit. Okay, and 3.4% of that total akan kata dia ada experience pain problem. But the stats yang clear is 1 in 5 people actually live in chronic pain. Okay, and something interesting yang kita cakap, kalau pain you order MRI, CT scan, X-ray, you cannot diagnose pain please. Jangan kalau apa sakit, okay lah you cakap sakit muscle, you diagnose the pain. No, that is to find the cause, not to find to diagnose pain though. Because pain is a symptom and the sign that we show. And different type of pain can overlap and change with time. And chronic pain can be due to, reason of system ongoing problem, body tissue. So all these things are inherent. Okay, we talk about the 4 P's. So we talk about prevention, we talk about psychological and physical. As you can see, the 3/4 ni non-pharmacological. And pharmaceutical is 1/4, 25%. So all these things are important in understanding, and if you really want to. If for example patient going to apa kita panggil GP ataupun kita punya KK kan, itulah the time tu tak ada, but to understand and to ask them what, of course we would to find the diagnosis dulu and what caused their pain, and from then we go on. But all these are actually important. As you can see, banyak tu, prevention, psychological, physical and pharmaceutical. Okay. Okay, but I have to really emphasize when we talk about is the communication and the understanding as well as the knowledge of what and who your patient is. The communication, doctor-patient communication ni penting ni. Okay, patient's perception, a patient's response to kita punya prescribed pain treatment influenced by a lot of factors. And sometimes the factors tu unrelated to the actual pharmacological treatment. So factors include the perceived effective communication. So that's why tak ada effective communication, you don't attend the pain. Bila patient, for example, patient tanya sakit-sakit, bagi terus kata bagi tramadol. Sedangkan patient sakit kat CBD. Kan? Kata hospital lah kan. So these things you must be clear. Pain, mana pain? Apa pain? And perceive responsiveness by the treating team. And perceive empathy by the treating team. Tapi itulah, cerita pandai lah kan, empathy ni. But in reality, sometimes it's difficult. I know. I've been there. I've been through the process. I've been, so for example, there are juniors there, or even students. I've seen and been in your shoes. And you know, like empathy bila you are busy as a house officer kan, kena buat benda, sometimes main tulis janji pergi, janji tulis prescribe je. So, but yeah, as much as possible as you go up and when you teach and when you educate others, your duties, so this is important lah. Okay, non-pharmacological, we talk about physiotherapy, we talk about psychosocial, and we talk about complementary medicine. Okay, it depends lah. Okay, depends lah kan. Macam, for example, physiotherapy kita pakai rest ni kan. Rest, immobilization, co-compression. Patient sakit kepala takkan nak suruh rise pula kan. Okay, so it's logically lah, in terms of pharmacological. But again, the psychological approach, explanations and reassurance. You can give that confidence to patient, memang you akan solve that placebo effect in terms of not just the drug, but the treatment that you give. Orang kata verbal analgesia tu. Macam mana you can, especially in addressing anxiety. Sometimes patient risau, especially yang kalau chest pain, check ECG okay kan, tapi then they put MSK pain ke apa tu, patient kata sakit ke costochondral pain etc. kan. So how do you address that and with your medication that you give? Complementary medicine, of course, is not something, saya selalu kata is multimodal kan. Macam cakap pergi jumpa sakit patah tulang sakit, pergi jumpa bomba tulang tu bagi tak sakit. Lepas tu tak nak x-ray kan. So it's just not that, but it has its role and according to place. So it's good as a physician or as a doctor who's in charge to be able to sort of like get this, because when you talk about occupational therapy ni penting later ni as they progress to recovery. That's why it's very clear that you have to know. Okay, there is this concept apa kita panggil preemptive analgesia and preventive analgesia. Tapi ini maybe we talk more when we talk about acute pain punya setting where patient going for surgery. You going for surgery, so you know mesti ada pain punya post-op. So these are the few concepts. I'm just throwing out this concept in terms of managing so that you understand and how the methods that we have can attain that and not just by medication. Okay, I mean ini kita ada simple charts and this simple chart memang I take from kita di KKM guideline tu lah, the fifth vital sign tu. So in the hospital again as you assess the pain, we talk about patient, okay lah under APS tak APS in terms of whether you big hospital or you small, pain tak ada, tapi we talk about pain score. And this is when you assess and based on pain score, you refer to the kita panggil the analgesic ladder. I will show you after this. In the primary setting, so in primary setting pun penting juga. When you're doing your pain assessment, then you consider to find what will be your working diagnosis and you attain the pain. And this is where the medication that you give, then you maintaining and understanding the pain score. And depending on when you see the patient the first time and when they come again for follow-up. Tapi sometimes patient datang sekali je. Patient, sakit kan, sakit perut. You tahu tanya-tanya, dia kata tak kisah, lalas bagi IM injection Voltaren. Not uncommon. So whether you are helping that problem or not, ini satu isu ni. So these are something that you have to be wary and understand when we talk about whether you manage it well or you mismanage. Okay, ini yang ni favorite punya subjek ni. Bila pain je ubat apa yang kita boleh bagi, ubat apa kita nak. So of course in medication in terms of ladder and what is available. So we talk out there, everybody has access di non-opioids, di non-opioids where the simplest yang paling ada overly selalu underrated is paracetamol, PCM ubat KK lah apa dia panggil kan, paracetamol. But paracetamol is very powerful because of bukan its direct effect but what it can do as an adjunct. Then you have your non-selective NSAIDs. Macam ni you tengok nama-nama ni kan, diclofenac kadang-kadang bukan you faham, tapi bila tunjuk ni Voltaren, Ponstan, Brufen, that is dia punya generic name and this is the trade name lah yang kita biasa pakai, Sinflex. bagi Mobic. Ni kan all this medication that we have and available, but depends on your hospital lah. What is available, but definitely kan macam definitely Voltaren ataupun diclofenac or ibuprofen, that or even mefenamic acid, which is Ponstan, something that you would prescribe. But to describe, kita selalu takut nak prescribe, kita describe satu. When it is very powerful when we use two, for example paracetamol dengan your NSAID together. Because what paracetamol is potentiate. If you realize things like macam Ultracet that we have is tramadol plus paracetamol. So why we have that paracetamol? Because it accentuates the effect. And kenapa kita tambah? Nak kurangkan side effect. Okay, the selective COX-2 inhibitor, you have your celecoxib, atrocoxib or paracoxib. Okay, kalau dekat luar sana, we call it the Celebrex and Acoxia lah. These two major brand by one major brand company yang akan keluarkan. And today I'm not sponsored by them lah to give this talk. And of course, paracoxib dan Anestat. Tapi, now if you go to the pharmacy and you ask for painkiller, dia akan tanya, you nak yang mahal ke yang murah? Because generics are all available. I mean, depends. Some people swear by the normal, macam Panadol kan, paracetamol. Panadol tu, yang color biru tu, yang itu bagus. Yang Euphemal ni tak bagus. Sedangkan dia punya formulation sama, but people swear by them. Again, the placebo effect and the effect, experience that they have. For example, orang komplain, KK punya ini murah ni paracetamol. Sedangkan if you go to maybe private hospital, dia beli yang generic yang paling murah paracetamol dia. So, again, there you get again. We talk about the opioids. Opioids, this is accessible that sometimes I mean for you can prescribe is the tramadol and dihydrocodone lah. Ni yang DF118 ni kalau tak silap. Okay. This is the letter. Mana my opioid? Sorry. Then opioid. Opioid ni sebenarnya is a taboo where dia pasal macam risau sangat lah. Kita risau sangat. Orang lain tak boleh pakai kan. So sometimes in ward they tend to not be able, tak boleh bagilah because of takut dia effect. Okay, fair enough. But then again, in terms of why work, if you are trained well to understand what are the side effect, how you give it, then it should not be a problem. So strong opioids are like morphine, fentanyl, oxycodone. Petidine. Petidine ni I nak komen sikit lah. Petidine is something that is still being used widely in our country. And maybe in terms of labor is traditionally something that is being continuously used. Tapi daripada WHO sendiri, it is not the essential pain drug because of the problems and side effect and the issue of addiction that can happen. Okay, alright, nalbuphine dan buprenorphine. So I pun maybe kita try, kalau nak habis cepat ni then tak payah kita talk about that sangat. Okay. Now the analgesic ladder. So what do you, how do you, ingat tak tadi the apa kita panggil tu, our flow chart. Okay, when we talk about where and what is the analgesic ladder, so we depend on kita symptom, kita punya pain score. So if the pain is mild, so either you give a paracetamol or combination with NSAID and COX-2 inhibitor. Moderate pain, kalau datang moderate pain, maybe you want to start with yang ada bagilah this weak opioids, tramadol. I mean this is what is available to you. And then kalau betul-betul severe, this is where morphine ataupun opioid base. I mean fentanyl maybe you tak ada lah. Of course morphine depends on which hospital you are or set up, but these are all control drugs. Or even oxycodone. Oxycodone, walaupun oxycontin, the drug that is yang cerita cerita pasal opioid the crisis di penyebab, but it is still available and the usage is actually dia ada oral yang but this is prescribed. I think Malaysia kita tak not really into this oxycodone, but we have been very traditional and conservative, which is good. Kalau tak, I think we would be one of them lah, because when you imagine at that point of time in US tu, dia prescribe tu macam prescribe Panadol. You have a paracetamol, of course it's over the counter, this one you need prescription, but doctors prescribe it freely and it is being like taken like paracetamol every day, because it can take, we boleh ambil 4 hourly, 2 hourly pun boleh tu, at regular intervals of oxynol. And that's why it happened bila dah banyak and the addictive effect, and the company at that time kata tak ada addictive effect, kan, it shouldn't be, but at the end of the day it becomes that. Alright, so I think we have come to the, I mean, again, my take-home message in terms of we talk about strategy is simple je, this ABCDE. You're able to do this because knowledge regarding medication and drugs sebenarnya is on your phone. Sekarang ni dah senang, you tak payah hafal. Anything you can Google. Alright? Even one thing that I did not touch again is about regarding your NSAIDs, your COX-2, what are the side effect. Macam morphine or opioids selalu yang what people feel is respiratory depression. Ini yang takut sangat patient tak nafas because of the metabolite. But when we talk about the other drugs, NSAIDs kan, macam you punya Ponstan, your Voltarens, all that you have to be careful history of gastritis. So ini semua all important lah in term of managing. So understanding the pain, bukan not just the medication that you give, tapi the side effect of what can happen when you give it long term, not short term, unless that patient memang dah ada initial, for example, history of gastritis atau memang ada reflux. So that definitely would cause them. So sometimes you give them in combination dengan your histamine antagonist tu kan, untuk dia okay. I think yes, moderator, I think that is all. And again, my take home message tadi, my ABCDE, and of course know your pain. Alright. Okay, kalau ada questions, I would prefer that and maybe we can discuss. Thank you very much.
Yeah, thank you, Dr. Mafeitz. Actually, we start having questions coming in dalam Q&A box tu.
Okay. Right.
Alright, kalau saya boleh bacakan. Again, thank you lah for the session tadi. Okay, dia punya soalan, how do we say patient have post-hepatic neuralgia and how do we manage it?
Again, question dia, how?
How do we say patient have post-hepatic neuralgia and how do we manage?
Okay, so again, it goes back to the pathology lah. When the patient come in with post-hepatic neuralgia kan, so it's a constant pain and dia ada banyak. And sometimes you get these patients yang, for example, katakan post shingles lah. Dia ada shingles kan? What do you call that? Chickenpox, and to manage it can be difficult because dia dah jadi chronic pain, neuropathic pain. So here, initially you want to address the inflammation. So of course, when you ask me about how to treat initially when they come in, you of course, again, sometimes kalau treat dia just by your NSAIDs ke atau apa, tak guna. So again, then secondly, you need to put in macam dia ada when you talk about chronic pain, dia ada this neuropathic punya drugs, for example macam Lyrica. But then again, the assessment again in terms of when you get diagnosis and how you diagnose it, because sometimes dia boleh red flag is something else that you treat, but if it's really common lah, betul-betul datang, especially that betul-betul dia punya sakit kat muka, ini yang memang pedih sangat. And sometimes it has to go chronic. Sometimes because when the inflammation settles, it's okay. But sometimes it persists. And if it is not managed well, this is a problem. The type that you may have to intervene later on because it can be very debilitating, then you have to refer to pain specialist lah. And patient specialist, of course, you kata biopsychosocial model dia yang dia ada. At the same time, dia ada pain injection and of course follow up and the medication that they take. So I would say that in a gist lah, because the question tu sebenarnya tu macam soalan masters tu untuk subspecialty pain kan, how do you treat kan, itu kena tulis satu essay for 15 or 20 minutes. Okay.
Mungkin fellow kot.
Yeah, for fellow lah.
Alright, yeah. So okay, the second question is what to monitor if the patient is on opioid?
Okay, so this depends on what is your setup. Okay, what is your setup? Because kalau daripada GP punya side ataupun KK, I don't think that you would prescribe. But depends, patient yang ada, maybe you ada orthopedics yang prescribe Osinon from the clinic tu ada. Tapi in the ward, there is something that we want to be careful. Nombor satu, di paling acute side effect dengan di long term ataupun some side effect yang kita tak perasan. Okay, yang short term senang lah. Opioid ni lebih sensitif. Nausea, vomiting ni sometimes patient datang dah sakit apa, you bagi dia muntah pula. It's actually worse. So that's one thing that you have to see how dia punya sensitivity to the particular opioid. But second, the most important sebenarnya is the patient, orang kata respiratory rate lah. The respiratory depression tu yang orang takut. That's why when they give, dia akan macam for example, the ward, kalau I think most in KKM dia tak bagi in the ward tu bagi IM, tapi dia bagi subcutaneous. Ataupun kalau ada APS service, dia bagi kita panggil PCA, Patient Control Anesthesia, yang patient tekan sendiri. The problem in terms of morphine dengan oxycodone, morphine ni dia ada active metabolite. Maknanya after 6 hours yang dia punya major dan dia pecah, dia ada metabolite. Metabolite dia actually 6 times more powerful, 6 glucose, ada 6 phosphate. Lagi kuat dia punya effect tu in terms of dia punya opioid. So that's why bila kita risau respiratory depression, bukan when you give. Katakan you bagi petang, you risau dia respiratory depression, pukul 1 pagi tu. Hence, when you take opioid, I think through KKM and the APS punya book tu dia dah ada. When every time patient opioid, dia ada monitoring chart and what to monitor. Respiratory rate is number one, saturation SpO2 is 2, and of course everything else because dia akan depress everything. And the other antidote is called naloxone. So it's something that you can give. It is in the guideline. So that's something that you can do.
All right, thank you. Then next question is how to treat phantom limb that regularly came to ED. Already
Oh,
referred to
okay.
orthopedic,
This is
but she keep trying.
very practical question because phantom limb ni dia sebenarnya dah masuk kepada neuropathic pain and chronic pain, which masa di initial part kenapa dia kena phantom tu maknanya kena amputate kan, which
Hmm.
was not managed well then. So in terms of when they come in, memang you have to give. I think I mean at that point of time, the pain score. Again, we go back to the basics of pain management, your ladder. And kalau katakan come to ED, ada satu guideline tu. Memang ED pun tulis how to manage because dulu kan memang bagi-bagi sometimes ada this. I mean those days lah. We're talking about maybe 20, 30 years ago. That ED can only give certain things, opioid tak boleh lah apa. But if you know how to give, when to give and what to monitor, that be okay. Okay, for phantom limb ni ataupun not just a phantom limb lah, because even phantom jari, ujung jari kena potong pun boleh rasa, because you have when you ask them how pain yang dia rasa, it be throbbing pain, it's not there, it's throbbing and it's very debilitating. So ni memang you have to refer for acute. At that moment of time, yes, you're opioid, but again, you don't admit this patient directly, but you need to attend and refer this to chronic pain lah, because there are a lot of things yang maybe they have to start with because even at that time, katakan you start your neuropathic punya sort of drugs macam gabapentin or the gabapentinoids ni, it will not work directly then, so it needs time, and hence the understanding the other part of non-pharmacological management for patient to understand the psychosocial punya cognitive behavioral therapy tu should be encompassed in to understand and the pain and how to live with that pain. That will be something that as simple as I can answer in this session lah. Alright.
Alright,
Ni Dr.
so
Fida ni tak nak. Dia cakap dia
dia
sakit mata tengok background, that one I tak cover lah for today
non-pharmacological.
Pharmacological. Okay.
Right, so okay, there's a next question. Any advice or comment on effectiveness, role of natural anti-inflammatory or adjuncts such as PEA or low dose naltrexone in chronic pain management?
Okay, so again, if to me in terms of effectiveness role of kita pakai all these things, sebenarnya is the complementary, and again is the overall. Bila kita add in adjuncts or something that we use macam tu you cakap tu, that is like kita panggil apa kita panggil tu? Kita panggil dia bukan the partial agonist. So dia not full in terms of pain, but again to understand and manage and to see, because sebenarnya there is no magic pill maknanya you bagi settle sakit tu, so you have to get that follow up and understand and see how does it differ from when they come in and what are the physiological functions that they want to recover from, because bila you ada this chronic pain, what it debilitates you is from you to return back to your normal function. You tak boleh buat, jadi you jadi sakit, so it becomes non-productive. You duduk tak boleh nak go and move and do what is you're supposed yang you buat lah, so that becomes frustrating. Kalau terus ekonomi or public health, dia dah jadi tak menyumbang kepada ekonomi, so you're not managing it well, so that change of time. Because at the same time yang initial patient bila acute pain, yes dia dapat MC, tapi bila dah habis that period, dia become chronic pain. Chronic pain ni mana ada MC, I mean unless it's cancer pain lah, that's a different story. But you don't have that. So to follow up tu, it's not easy lah, bukan senang. It's not. I mean, the setup tak semestinya as a pain specialist. I believe in the GP setting when you have patients who come in and you have this knowledge to understand and to see how you can improve them. I think that will be my comment lah on that particular question.
Yeah, next questions. They ask your experience with your recent visit to Gaza.
Okay.
Uh,
Okay. Yes, it is something, it is, as I said, it's a different spectrum because you have this knowledge, you understand what pain management should be and what you are used to. And you come to a situation where you don't have enough resources, one, and number two, you have to choose who would benefit from the limited resources you have. For example, bila I datang, fentanyl tu memang tak ada langsung. So I had to depend on certain medication. For example, if in disaster medicine, your pain and everything, one magic drug lah, ketamine tu. Tapi post op pain, patient come in with blast injuries apa semua, the development, definitely what happens there, patient yang ada acute pain, dia memang tak akan settle and they will end up, if the whatever carnage is happening there settle pun, the issue of pain will be very 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 bad. And patients who are, orang kata dah addicted to ketamine or even certain opioids pun is already there because they keep coming in and the injury is not settled. So I would say that is the experience in that sense lah in manage. And sometimes your psychosocial yang apa non-pharmacological ni banyak mana pun dia boleh buat. As a physician kan, you know you can do, but that is what you have. So antara benda kena just dia sakit terang-terang tu, what can you do? So if you're in that situation and the patients keep coming because of the blast that's been happening and being brought to you, and you have to manage to filter them to see where to send, how to manage the pain, tak senang. Jahit tak ada local tu standard. So imagine these small kids kan. So what is the method? Pegang ramai-ramai, shushu, baca Quran. So you know these things that's happening in front of you and it keeps going and it has not stopped, which is to my sadness and the what we as a world cannot do anything and just see that happening. Okay, next. Okay.
Yeah, great insights. Okay, next question is for fibromyalgia. What is the best management? I think ni
Fibromyalgia.
macam nociplastic pain juga lah kan.
Okay, fibromyalgia. You pun tahu definition apa fibromyalgia kan? Apa you dah diagnose everything else. Diagnosis of exclusion,
Diagnosis of
fibromyalgia. This is the
occlusion.
difficult part sebenarnya. So in terms of role or the treatment, it's multiple and memang multifactorial lah. Because patient will come in with pain kat sana lah, and then lepas tu minggu depan kat sini lah, you bagi ubat mula okay, then tak okay. You know, so this is the skill in the sense of how you can empathize and help them as long. But see, diagnosing fibromyalgia maybe at one time of point, but then again, when they come in, you have to do a complete examination again, a complete assessment because the pain can be something else, which has an origin, which can be treated in the sense of something you can intervene. But otherwise, those of fibromyalgia, the non-pharmacological may be more important or maybe more effective than the pharmacological. Because the pharmacological, the problem, if you consider keeping their own musculoskeletal pain or fibromyalgia, you bagi dia orang apa say NSAIDs, then in the end you will end up rosak kidney pula. Marah Dr. Rafidah. Datang lagi. Kenapa makan pain tak settle-settle? Jumpa how many patients yang kena transplant because of their excessive taking NSAID. So these are issues that's why fibromyalgia is very complex. You tak cakap lagi ada satu myofascial tu. Myofascial punya pain. Ini chronic pain pun ada di intervention dia jugalah. Alright.
Alright. Okay, next is there any role of regional anesthesia as part of multimodal pain strategy? For example, erectospinal,
Yes,
plain
PB.
block or rib fracture.
Oh yes, definitely. When we talk about multimodal pain strategy, that is the keyword and that is how one should manage. Bukan takut bagi satu ubat. Patient may be reluctant lah nak makan ubat banyak-banyak and they wouldn't. But yes, definitely rib pain, ESP and blocks. Blocks ni we go back to the simple, but this is only for acute pain. Or chronic pain ni susah sikit kita nak katakan blocks to help because it's different. Tapi for acute pain, dia simple je. If you remember that diagram that I showed, dia ada the peripheral nerve, you ada tengah-tengah tu dekat dorsal, dekat dalam spinal cord and then above to the brain. So peripheral nerve, that means nerve ni, how dia conduction kan, is kita tahu action potential. So local anesthesia is sodium channel blocker. So what sodium channel blocker does, it blocks the transmission of from dia punya efferent tu. So block, tak sampai ke spinal cord. So that's what blocks would do. So ESP, ini yang kita panggil sexy block lah kalau amongst the ED physicians or even the anesthesia. So one block that really helps, especially in rib fracture, because of dia punya reduced rate of possible complication. If you train well that enough, it's actually easy to do. So yes, is multimodal is the magic word to attain when we talk about pain management.
Alright. Okay, one more questions. Can you suggest approach patient presented with chronic pain, example lower back pain requesting longer MCS, the patient felt unfit to work. They
Okay,
refer
this is
medical
a
board lah.
very practical question. Ini memang soalan subspecialty pain. You have this in dia punya written and you have this in terms of your approach in the sense of talking. Oh, ini soalan exam ni ke? Ni prof mana-mana ni tengah nak tanya saya. Saya tak ambil pain prof. Okay, anyway, alright. Okay, again, in terms of when you look at this particular question, low back pain, dua benda yang patient come into you, come in minta MC, satu migraine, headache, satu lagi low back pain. Ini datang macam-macam and in terms of recovery. Again, when we talk about the approach, okay, I go back to the other guideline. Ada satu yang macam kita punya KKM punya juga, ada specially keluar ni, low back pain. Exactly macam tu, low back pain. I mean, you can refer that, you can Google, and then dia ada satu CPG memang akan refer everything in terms of your direction where you going with it. Again, in knowing low back pain, you have to rule out what are the most common issue. Yang macam-macam yang ada betul-betul physically dekat back pain tu. Is it related to a fracture? Is it related to a disc? Is it a prolapse thing? Or is it something, a compression of the nerve? So when you have ruled that out, then dia start lah yang pain, yang lain-lain yang bila tak didiagnosed and it's not just kita di Malaysia, it's all over the world. Low back pain is very, very, very common. So there are multi macam cara to attain that lah. Of course, in terms of when they come in acute pain, they can't function, and when you clinically assess them, memang kalau patient datang relate bawa kereta sendiri datang, oh I got low back pain MC, itu minta you punya budi bicara in the sense of your ethical thing, whether you should or you should not in terms of giving that medical certificate for the particular disease. But if they can't walk and debilitated, so yeah, of course they do that. But in terms of the thing is the assessment and to see and to diagnose at that point of time and to relieve that acute pain that they have at that moment. So yeah, we go according to the ladder juga. And again, your examination and investigation. Examination ni, if you look at the guideline dalam low back pain yang Malaysia, our KKM punya specialist all, they comprise of orthopedic, anesthetist, sports physician plus, the whole setup tu, they all type of examination to say clinically what would be the possible problem ada. So yeah, please have a go through look that for your particular question. I jawab you punya question dengan satu guidebook tu. Okay, alright.
Alright. There's one more questions. Multiple allergic drug. It's genetic allergic. Post-op only PCM. I think question ni dia kata patient tu only can take PCM. How doctor treat this pain if she refuse morphine but pain not tolerable with PCM?
Okay, ini pun very common I think in terms kita. So number one, sebenarnya kita kena attain and understand bila patient define as allergy tu apa. Because sometimes when they bila dia just ada merah-merah gatal, then dia kata allergy. Okay, so that is the definition that you have to be clear and that history taking lah. Tapi kat hospital nak berani-berani tak bagi, rasanya you akan ambil lah. Because again, we go back to apa patient cakap, we take and we take that. Alright. And then they refuse morphine but cannot tolerate. Again, ini depends on where pain is. But again, daripada yang benda ni is the initial when they come and what are they used to lah. What are the medication yang dia selalu ambil yang help them relieve that pain. And then in terms if cannot tolerate with the paracetamol on its own, kalau pain score dia more than 3-4 memang tak cukup. And as you can see tadi, kalau kita ada kita punya ladder, we talk about pain score 1 to 3, paracetamol may have a role there. Apa-apa kata tak ada. So one of the choices is tramadol. Kalau dia tak nak morphine opioid based, tramadol. Tramadol sebenarnya is not really opioid lah, but it affects on some opioid receptor. It's a mechanism yang sometimes not understood. So that would be something that you can use. You can attach. Macam tadi kalau dia tak boleh paracetamol, dia kata dia NSAID punya allergy. Dan selalunya, okay, there is this misconception lah yang kita ada bila NSAID dengan COX-2 inhibitor ni, okay, COX-2 inhibitor dengan NSAID ni kita ingat sama. Maknanya Ponstan dengan Akoxia tu satu geng. Sebenarnya it is not It is not. So because you see with dia ada dekat acid punya pathway tu, where you have your cyclooxygenase punya pathway, where you have your enzyme 1 and enzyme 2. So COX-2 ni dia spesifik. So banyak side effect yang katakan with your NSAIDs, especially allergy, COX-2 ni tak ada. So maybe you can have a go with that. But again, understanding what allergy means and understanding how it affects, because allergy ni kita takut it become anaphylaxis. So bila anaphylaxis ni dah boleh jadi anaphylactic shock, dah cerita lain pula kan. So that is the issue. But again, maybe yalah, patient tengah sakit kan, you nak cakap lah, nak empathy kan, kadang patient marah maki-maki kan, so you can't really macam tak tahan. But that is something that, but again, the program of pain relief medication, you may help the patient to understand and go through with them. Simple example would be, say for example, katakanlah positioning je. You help them positioning, you tanya if that, so you encourage that to the patient. Ini just example lah, certain example. Okay, alright.
I think one last question before we end. What is the best painkiller that can started for drug addict? Kaki ketum, because it got
Mak, ni betul,
experience.
Prof ni.
Fentanyl, petidin, morphine pun tak berkesan.
Okay, true. Okay, so at this point of time, when patient come in, especially patient with drug history, so this can be attained because sometimes what can happen because of biasness, kita tak nak bagi dia. And you are right, that when they are opioid addicts, okay, now bila patient come to you and with the history of drug abuse, kita kena be careful because sekarang ni dua jenis drug. Kalau dulu, when I was a student before, we only talk about opioids. So opioids, so opioid ni addictive. Yang satu lagi sekarang ni is the new drugs ni, yang macam meth, all these stimulants. So they act two different way. Okay, what is the best effective? Kalau on the side at that moment of time, sebenarnya the requirement may be more that they need to take, and you have to give as banyak as possible at that moment in time for their relief. For example, macam katakan lah, we have that 1 mg, 2 mg per kilogram sort of like punya limit, but you have to give as how he needs. Kalau dalam pain management, pain is when they tell you, macam katakan for even Mafeitz, sebenarnya when patient tell you that dia masih sakit, you can still give continue, but you have to monitor. Again, when you talk about addicts, there is something that, again, if you're in a hospital setup, you need to get the advice of the particular pain specialist yang ada, or even anesthetist, because one thing that is something not really used, the adjuvant with this particular patient addicts is ketamine. Infusion IV ketamine. Okay, they should be in tandem. Infusion kita selalu kat Malaysia pun dia tebu ni dua. Satu opioid, dua ketamine. Takut sangat. But then again, I don't blame people because when you don't see it work and we don't ready available, so orang pun memang tak pakai. But for addict, you need to have that base ketamine because ketamine ni pun adjunct. It's just how paracetamol can help to increase the efficacy of their other medication. Ketamine is one where it can increase the efficacy of your opioid. Some other the morphine or fentanyl you use. Kalau petidin ni, I wouldn't encourage dia memang petidin addict, you nak bagi petidin because petidin punya mode of action memang short and you akan memang takkan bagi. So you have to change definitely to the stronger opioid of fentanyl or morphine, but with that infusion, or depends lah, patient come in to you definitely as inpatient or maybe post-surgery with history of opioid abuse. Hence, that management in terms of ketamine infusion and where you can incorporate to give, katakan before operation, pre-op, and perioperatively lah, and then after tailor down. Okay, thank you.
Okay, I think that's all for the question for the Q&A sessions. It's already 9:34. Alright, okay. So I would like to take a moment to extend our gratitude to Dr. Mafeitz for sharing his expertise and practical approach for pain management. I think a lot of information has been gained from the session, and I hope the knowledge you shared tonight will certainly help us improve the way we care for the patient and also manage pain more effectively in our respective field lah. And then to all the participants, thank you for the active engagement throughout the sessions, and we hope the key takeaways or take-home message or important diagrams, flow charts that are prepared for us tonight will serve as important tools for our clinical practice. So whether it is integrating the new pain management strategies ataupun kita nak refining protocols or maybe applying multi-modal approach that better meet our patient needs. So, alright. So please don't forget to complete the form to claim your CPD point using the link provided, and you will be also receive your e-certificate later. Alright, once again, thank you all for being part of this webinar, and we look forward to seeing you again with the new topic next month. And please wait for the announcement from our various social media platform for our MedTweetMy many type of program that will be served for us. All right. Okay. Thank you, everyone. Assalamualaikum.